So I'd like to introduce our first speaker. Many of you know, this is Heather Carmelo. Heather is an ophthalmic photographer and imaging specialist with over 20 years experience. She is the lead ophthalmic technician at Rochester Regional and adjunct faculty member in the Rochester Institute of Technology's biomedical photography program and serves on the board of directors for the Ophthalmic Photography Society. So she is quite accomplished and she's been doing this a long time. Heather is a graduate of the Rochester Institute of Technology, RIT, and has obtained her bachelor's degree in biomedical photography. She also has a master in health occupations education from the U of R. She has obtained numerous certifications, including retinal angiography, OCT, ophthalmic assisting. So please welcome Heather as she presents how preclinical workup affects diagnostic accuracy. And actually, I correct that. I think it was actually diagnostic testing, can we do it or not? So yeah, little combo. All right, please welcome Heather Carmelo.
All right, good morning, everybody. So we're going to start out by talking about how diagnostic testing impacts how techs order the testing and what happens. I do not have any financial disclosures. What are we going to discuss this morning? So we're going to talk about what tests look like, how incorrect orders or tests affect outcomes, what tests look like with inaccuracies, and a few cases of combined studies. So when, where, and why? Can it be done all in one visit? So how many of you are in the diagnostics department? Okay. So you know that you do a lot of tests, right? And some of them are more challenging than others. Yeah. Some of them take a little bit longer than others, right? Sometimes we have to go to the hospital floor, correct? Yep. And then sometimes patients come to us. So the first thing we have to know is, do we have a definitive diagnosis, or are we looking to rule something out? So I'm going to pick on the diagnostics department a little bit this morning. Sorry. So the things that we want to think about is, if we're doing multiple tests in a single visit, what is the best order of what we should do the tests? When should we do them? What should we do first? We need to consider the tests that need to be performed and the capacity of the patient to handle all of the tests. Sometimes we have very sick patients, correct? Mm-hmm. You know, and we have to think about their capacity. And then we would recommend non-contact tests first. So I'm just going to kind of give an exhaustive list of what the diagnostic imaging department does. So we do spectral domain, or OCT, including anterior segment and angle. So not only are we looking at the retina, but we're also looking at the anterior segment. They do fundus photography on 2 different imaging modality pieces of equipment. They do fluorescein angiography, ICG, AHRA, Humphrey visual field, Goldman visual field, and 100 hue D15. So we're getting into a pretty exhaustive list already. And why this impacts what the technicians do is we have to work together as a team, because a lot of the tests, like for example, that are done at the hospital, that's where a lot of the tests are done, correct? So we have to think about what needs to be ordered, what is the capacity of the patient, what does the doctor want, what do we think is the bandwidth. We do slit lamp photography and goniography, which can be contact, topography, specular imaging, external photography or videography. We do ERGs, a couple different types. We do IOL master, A scan, UBM, or B scan. So how many of you think this is a lot of tests? Show of hands, right? It's a lot. It's okay. Have some coffee, wake up a little bit more. We got this. So some of the obstacles to overcome is disruption of the corneal surface. So we have to think about, if we're taking fundus photos, but then say we do gonio pictures first, do you think that's going to be more challenging to take the pictures? Diagnostic, yes, right? Doing testing that doesn't require dilation prior, because sometimes dilating our patients will impact the results of our tests. There's kind of a phenomenon called bleaching, where the patient's vision prevents further cooperation or fixation for other tests. So how many of you go outside in the bright sunlight and then come indoors and your vision is bleached? Imagine you're low vision and you're walking around the clinic trying to get all this testing done, and you already have low vision, and then, imaging has to take pictures and bleach out your vision. So we want to think about the ability to help each other as a team with helping these patients navigate the offices too, because the bleaching phenomenon is pretty intense for some patients. And then we have to tell an overall story of what is happening with the patient. So we may have a patient that won't have a superior outcome of cataract surgery, perhaps due to pathology elsewhere. What if they have macular degeneration? So how many patients do you see with macular degeneration? A lot.
Wow.
Right. So these patients are walking around with this central scotoma blind spot in their vision, and then they get cataract surgery, and then they get IOL measurements, and it's challenging. These are obstacles that we have to think about. So just some examples of imaging. We do retinal imaging. So we got color photos, we got angiography. On the HRA machine, so when we do these images on these patients, we have to do 4 different types of images. And these 4 different types of images come with 4 different brightnesses of light. So this is where that photo bleaching comes into play, is these patients, come in and some of that light is super bright. It's super bright, especially the last 2 images. When we blast those patients with that bright light, they notice, right? So as a team, once again, helping these patients navigate the clinic. So we have Goldman visual field. Do we still do Goldman visual fields in the clinic? Are they easy or are they hard?
They're difficult.
They're difficult, right? So these tests are a little bit more involved. They take more time to do. So when the technicians are kind of checking in on diagnostics, saying, I just wanted to get a time frame, how are things going? This can take upwards of probably a half hour, right? Yeah, sometimes more, right? Because what we're doing, just for context, is we're actually sitting these patients in a giant bowl, and as the imaging specialists, they bring the light in from different directions, and we're mapping out this patient's visual field by hand, manually, one by one. So if you order Goldman visual field, or the technicians are like, what's going on with this Goldman visual field? It just wanted to check in, the doctor's asking. Well, we're mapping out someone's vision, okay? And we do it for several different reasons. So we do it for plastics. So when we do it for plastics, we typically do it to check for patients that have dermatochalasis, right? Do they need lid surgery? Do they qualify medically? Is insurance going to cover it, to be quite honest? Or we have patients like this middle one right here, where they have a very large scotoma in the center of vision. They have random constriction of vision. They have very indescribable, inconsistent responses when they take the test. And then we have ones that are pretty average or pretty normal, and everyone has a normal blind spot, right? What is a normal blind spot? Can anyone tell me? Yeah, and it's basically where the optic nerve enters the retina, right? There's no photoreceptors. So we have to map that out well. And we want to determine whether or not that blind spot is bigger than normal, or is it average? Is it to be expected? Humphrey visual fields. So there's differences between Goldman visual fields and Humphrey visual fields. So Goldman is kinetic. It requires movement. Humphrey visual field is static. So what happens is every time a light comes in the bowl, the machine is doing the work. We're doing the monitoring and making sure that the patient is doing what they're supposed to do. So we can't just sit there and be like, oh, start the machine, everything's fine, I'm just gonna do my thing. No, it's a little more involved with that. And plus, we probably do CETA standards still pretty regularly. So the difference between CETA fast and CETA standard is time and plots. So with CETA fast, the average test time is about 3 to 5 minutes. CETA standard is upwards of 5, 7, even 10 minutes per eye. So once again, as the team, I can't stress the teamwork enough, is understanding what's happening with these patients, where they're going to be, how long they're going to be, and just getting a feel for what to understand as a team is what's going on. So moving on to corneal imaging. So we're assessing astigmatism, we're assessing pre-op and post-op, helping to diagnose corneal diseases. So how long does a corneal topography take? 5 minutes? Yeah. So these are pretty quick. So I want to stress the importance of just understanding, you know, what your teammates are doing, how long things take, kind of an average, and that next level thinking of saying, you know, I know that this patient has a Goldman visual field ordered. They have HRA photos ordered. They have OCTs ordered, and you're wondering what's happening, you know, or a patient just goes back for a corneal topography. Just takes a few moments, right? So just some examples, you know, with the rule or against the rule, astigmatism, understanding what the layout, you know, literally the topography of the cornea is. So they also do corneal imaging. We do specular microscopy. So we're basically understanding what the cells look like. So the image on the left is basically normal corneal endothelium, but the image on the right is abnormal corneal endothelium. So how long on average does this take? Yeah, depends on the patient, right? It depends on, you know, the ability of the machine to kind of navigate sometimes, because some of these patients are a little more challenging than others, right? Sometimes they're a little bit harder to do. They take a little bit longer. The other thing is, you know, are we still able to export, or do we have to print these out and scan them in? Right? So we have that to think about as well, is accessing this information, getting it into the patient's chart, and having a completed product for the doctor to review. So this is non-contact imaging. So anterior segment imaging or slit lamp imaging. So this helps us show pathology. How many of you love slit lamp imaging? It's awesome. Okay, it's great. It's very interesting. There's different lighting techniques, and the department should follow a protocol. So it's not just one image and we're done. A lot of the times we have to tell a story with slit lamp imaging. So if a patient, you know, has slit lamp images ordered, and then they have, say, a Goldman visual field ordered, or they have, you know, endothelial imaging ordered, right? It's compounding, it's adding up. So when the imaging department does this probably takes an average of 15, 20 minutes, you know, depending on the patient, depending on what's required. But we have different lighting techniques that we can show different pathologies of the cornea, of the sclera. So there's different names for all this. There's diffuse imaging, there's thin beam imaging, there's thick beam imaging. There's what's called sclerotic scatter up in the top left. There's ability to show texture. So say, you know, you're working with patients that might have a questionable tumor or growth, you know, on the iris. Imaging is able to show what that looks like by textural imaging. We can show if there's lens problems, lens pathologies in the eye by doing what's called retroillumination. So this is on average, you know, 15 to 20 minutes, depending on what we are looking at and what we're trying to demonstrate. Any questions so far? Okay. So moving forward, how many of you order IOL master for patients? Pretty regularly, right? So what is it that we're doing when we do IOL master? Anybody tell me that's technician, not in imaging? What's that? Yeah, measuring the lengths of the eye. It sounds very simple, right? And it kind of is, but at the same time, there's much more involved when we're doing IOL master. So there's a couple of important things that the techs need to, point out to us in imaging or understand what we need to do. So we have to know if patients have had eye surgery before, such as a vitrectomy, silicone oil, or gas in the eye, right? Because sometimes patients get retina surgery and then they get sent back for IOL measurements because they need cataract surgery or they need a new lens implant, for example. Have they had corrective or elective surgery? Asking these patients, have you had LASIK? Have you had PRK? Have you had RK? Have you had any of those surgeries? The state of their eye. Are they phakic? Are they pseudophakic? So what's phakic? Right, it's your natural lens status, right? Pseudophakic. So even though patients have had cataract surgery before, a lot of the times the doctors want measurements of that eye as well. So we have to figure out all of this information before we actually start doing the measurements. It's a little bit harder to go back, okay? Have they worn contacts? So what's the protocol now for contact lens wear? 2 weeks, right? So why do you think that matters? I hear lots of answers. I love this. Right. So, when we're measuring cornea as part of the IOL master, if the cornea is impacted by contact lens wear, it can impact the measurements. And then another thing that we need to know is what is their target refraction. So sometimes it's plano, right? Sometimes there's no target refraction. Sometimes there's minus 0.5. We also need to know that as well because we input that into the machine. So there's a lot of thought that goes into these measurements, into what we're doing for the patient. So many of you would want to have cataract surgery, being told that you don't need glasses anymore except readers, and then you come out of cataract surgery needing -3 glasses. Would you be happy? No, definitely not. Right? So all this information matters. All right. So let's discuss some outcomes. So ordering tests correctly, the impact. Oh boy. All right. So for example, someone ordered a Goldman visual field in both eyes. Judging by the clinical presentation, do you think we would get a Goldman visual field on the right eye?
No.
No. Order the correct eye. Take a look at the chart, next level thinking, put it forward to diagnostics and say, hey, this patient has no vision in the right eye. I just ordered a Goldman visual field lens eye. And then we take a look and obviously we have the lids taped because we're going to take clinical photographs, but wanting to see, the presentation of this patient. So say we do anterior segment OCT imaging. What's different about the image on the left? Contacts.
There's a contact.
Yeah, so they're wearing contact lenses. And it kind of smooths out the cornea, right? But the image on the right, we can see this little deviation right here. So it makes a difference what the outcome is, whether or not contacts are in or out. So if patients wear contact lenses, that influences the diagnostics team a lot. Do they want the image with the contacts in and out? Perhaps. Maybe they want both. So, do we want external photos or do we want slit lamp? Kind of want both. Yeah, something going on here. Shock value, I love it. All right, so what lies beneath, right? what is happening with this patient? You know, clinically, we do our what is our called raccoon view image of external photos. So when you order external photos, the top result is what you would be asking, you know, of the patient and of the clinical diagnostics team to do. However, slit lamp photography tells us a completely different story, right? And then we do more slit lamp images. I'm going to be honest, I don't even remember if this is that same eye, but overall, we get a completely different story if we take slit lamp images, corneal images to show what the cornea looks like on the same patient, but perhaps in 3 different scenarios. So we got 3 different influences on what we're looking for. How many of you do OCTs? Majority, right? Are they easy most of the time? Most of the time.
Yeah.
Yeah. But sometimes we get some roadblocks, right? So the image on the right, how many of you find this acceptable? It's okay, right? We got something. You know, you have to look at the scenario. Sometimes, you know, if you see a patient whose vision is like 2400, they have a keratoprosthesis, you know, you really can't see a view in. This is what we may get, but the doctor may be happy with that. Hello. All right, so next question is, OCT has algorithms that pretty much do a lot of the work for us, right? So the image on the left, does anyone have a problem with it? Take a good look at it. Does anyone think something's amiss? There's something wrong. Yeah, it's not centered, right? If we look there, okay. I purposely moved it because it impacts the ganglion cell analysis. So instead of having green means go, you're good to go, patient, everything's okay. Now we got what, salmon pink? Is that what the color is? Red? You know, we got a little bit more alarming values, but it's not because of the patient's eyes, because it's misaligned. So I encourage, you know, diagnostics to really take a look at some of those difficult ones or some of those misaligned ones and say, am I conveying the right information? Or you work in the satellites and you do OCTs. Am I conveying all of the right information? So who wants to venture a guess on why the image on the left, the OCT image, looks poor? Could be cornea. Sure.
Focus.
Out of focus.
Cataract.
Dryness. Yep. Something's going on. Yeah, it could be a number of things. But guess what it is? The patient is aphakic. This is the same patient focused on the OCT machine. You know how you have the focus module? You focus plus. You're compensating for lack of a lens. I did not know that, so I created the image on the left first. And then I asked the patient, I'm like, you have a giant macular hole here. I'm like, something's going on here. I said, have you had cataract surgery? He's like, I don't have a lens. I was like, oh, okay. That's good to know. Thanks for sharing. You know, it's like, that's where your head goes, right? But what we're talking about is simple, you know, use the machine to your advantage. You know, using the focus module, getting a much better quality scan on the same patient, same day, minutes apart. Can anyone appreciate what that arrow is pointing to? I know it's kind of hard to see in here, but you can see that this patient has a lot of retinal pathology, a lot of disease process, scarring, right? And right here, I was like, that looks a little bit different. I was like, it just doesn't look the same as the scarring. Okay. So next level thinking, talked to my boss about it. I was like, I don't know what's going on with this spot. It just looks a little strange. So then we took a look at it. And she's like, yeah, I agree. Fun fact, we took off the Optos cover, you know how it's removable. It was a piece of plastic. It was a piece of plastic still on the back of the panel. You're welcome, Diagnostics. I got rid of it for you. But what happened is, you know, on the diagnostics team, there's a lot of things to think about, a lot of things to consider, a lot of things that we can have happen. So I brought the patient back in, and lo and behold, it's gone. So if, you know, you're a technician, you know, something's a little bit different or unique about this patient, you see a lot of challenging patients, right? You know, and we have a lot of things that we have to think about. And now we have to think about what could be wrong with our machine or our equipment. What's going on with that? Okay, this one's a little bit easier to see. So what, does anyone think this is artifact or pathology? No. It is an Ozurdex implant. Oh.
What implant?
Ozurdex. So what happened, notice the shape, right? It's a little bit straight, but all the lashes are going a little bit differently. So what I like to encourage is take more than one image, have the patient look a little bit in a different direction, and see if the result is repeatable. Does it move with it? Does it not move with it? So once again, diagnostics has a lot of things to think about. Technicians have a lot of things to think about. You're like, oh, this patient's going to be challenging, or this is going to happen, or this is in here. And we have to think about what could happen or what could be in our pathway that we have to think about. What are we delivering to the doctor? Here, everyone said artifact, but no, it's an implant. So then here's some combos. So how many of you think the OCT image is okay? Questionable, right? But if this is the view on the Optos that we're working with, that's not so bad, right? We got a pretty dense cataract in the way. How many of you have seen patients with a K-Pro? Right, a lot of you. So a lot of the times your scans can get pretty good, but also they can be not so good sometimes. So taking a look at this patient, you know, the window of the view is minimal because there's a little bit of a different level of thinking with these patients. You know, they have that permanent opening, so to speak, but then are we dilating behind that? Okay, how many of you image patients with gas bubbles and some days you can't get it? You're racking your brain, you're like, come on, OCT, you can do this for me, right? So we start out with our pre-op macular hole, and then 2 days post-op, this is the best we can get. So when you're doing OCTs, when you're looking in the machine and when you're looking at your view, you know, you line up the pupil, right? You know, you get your view into place, and then you line it up and you're like, I can't see anything. Next level thinking is, what is it that I'm looking at or what I'm looking through? So 2 days post-op, I don't even know if I'm in the right spot. It's that challenging. 3 weeks post-op. Who thinks this OCT is acceptable? The gas bubble has completely occluded the view, right? So depending on which day or what time frame these patients are coming in is what you're going to get, what your result is. And then finally, you know, a couple weeks post-op, pardon me, I think it's like 4 weeks post-op. We have a little bit better view and we can see because the gas bubble is starting to absorb. How many of you use the fundus camera to do angiograms? Right? You still have the Zeiss? Yep. So view on the left, less than ideal. I go to the Heidelberg. Can we do it or not? Yes, we can. We go to the Heidelberg, which uses confocal scanning laser. So it's a little bit different of view, a different technology. We get the same image maybe about a minute later, and we get a completely different view. So the other thing that we have to think about is, do we talk to the doctor and say, I switched machines because this worked a little bit better? I got better images. Almost there. All right, how many of you know what RP is? Right, retinitis pigmentosa. Yep. How many of you know that patients with RP can also get cataracts? And they have a very minimal constricted field of view, right? Their field of vision is only 10 degrees. So this patient's got a lot of complexity to their case. Their pre-op vision's 2150, 2200. So we take a fundus photo, an external view, and we show that they have a central cataract. And then we do an IOL master, and we're not going to get an axial length measurement. So we have to go to ultrasound. We have to do a scan. So this is where it comes into play again when, you know, technicians have to check in. The doctor's like, what's going on? What's happening? It's like, well, we have this complex case of a patient with RP, cataracts, getting photos, getting visual field, doing an A scan, which takes a couple minutes because you want to do multiple measurements, right? So this is complex. So we have a case of a patient who every time they come in, we want to make sure they're not dilated first. So take a look, you know, in the chart. Do we want to send this patient to diagnostics dilated or undilated? So do we see anything remarkable? Or does this look like a pretty normal eye? Pretty normal, right? Now we dilate. Now we have something going on inferior. We have a little bump going on. And then diagnostics has to go next level. We have to do an ultrasound biomicroscopy. And what's hiding beneath is a potential growth. So they come to us undilated first, then we dilate them. So we do a measurement this way, and this is what we get. So fundus photos, sometimes we have to do different views because we look at the first image and, you know, it's like, okay, looks like a normal color photo to me, but then the patient looks superior and all of a sudden we have a nevus that we have to get ICG or infrared images on. So just a combination of when diagnostics is doing Goldman visual field and ptosis photos. So we can see that the solid lines are untaped and the dotted lines or the trace lines are taped. So you can see a significant difference. And if we combine the photos together, makes a lot of sense, right? But what we're doing is hand drawing this once again, taping the patient, doing the same test again, and then taking them into a different room or possibly the same room and taking photos as well. So how many of you feel this visual field is pretty abnormal? So testing orders the visual field and they're like, oh, something's going on. Oh boy, someone's going to the OR, right? So we get this, you know, order to just do visual field, but then diagnostic goes a little more in depth. They order more testing. They find out that they need OCT, and then they find out that they need to go to the OR. I'm just going to skip through because I'm running out of time here, but we have OCT and angiograms, which is pretty commonplace. We have a Stargardt's case where a patient has central scotoma, but take a look at the photos. It matches almost, right? So we can see that they have this large central scotoma, which matches the color photos. But thank you to the current team. You guys are doing fabulous. Thank you for all the technicians, and thank you for listening this morning.
Yeah, I have one question. Anybody?
Yeah.
Yeah, Heather, great talk, by the way. Really appreciate that.
Thank you.
So, couple of comments. Number one, for the gas bubble OCT, day 2, post microhole surgery, physicians should not order that.
Mm-hmm.
We not
Okay.
helpful, and we know for sure you won't get a good image.
Right.
Week to order OCT for patient who set up for micro surgery.
Yeah.
Number two, for the visual field, make sure, again, this is for providers. Check patient, figure out what's going on before you order more time-consuming diagnostic test.
Yeah.
RD, do not order visual field.
Right. Yeah, it was a very uncommon case.
And number
But it happened.
comment on that visual field. If you look at the folio number, it's like 19, which is really telling you the marker is not right.
Right.
Be like 30, 35 for it to even make sense. Number three is I like to see fundus autofluorescence. For any optos photo, fundus photo, that give you a lot of additional information for the pathology. So that's my comments.
Thank you. Thanks, everyone.
Okay, our next speaker is Dr. Diana Joseph, who's finishing her final year here at doing her residency. She's originally from Chicago, Illinois, and attended Duke University. There she earned a bachelor's degree in computer science. She immediately landed a job as a software engineer, but a family member's glaucoma diagnosis inspired her to return to school to become an ophthalmologist. Yay. Not yay for glaucoma, but the ophthalmologist. She completed her medical degree at the University of Rochester and has been involved in several research projects with the FEI faculty. She recently published a paper about biomarkers in retinal disease in Frontiers in Ophthalmology and completed training as an Epic Smart user. So feel free to ask any questions to her about Epic that you have. Diana also likes to stay active and is trained in several styles of Indian classical and folk dance. After graduation, Diana plans to pursue a fellowship in cornea. And this morning, she's going to speak about preoperative considerations for cataract surgery. All right, let's welcome Dr. Joseph.
All right, hello, everybody. Just to clarify, I'm finishing my third year, so you're not rid of me yet, don't worry. I'm very honored to be presenting today. This is a very challenging talk to put together because some of you have been with us for like a couple years and some of you have been with us for like 30 years and could probably give this talk and know way more about cataract surgery than I do. But I hope everyone learns at least something. My inspiration for this talk was, let's see, a lot of you are in our clinics doing the initial workup for these patients for cataract evaluations. And this is like a common dot phrase that's used. And there's so much that goes into the history for a cataract evaluation. And I just wanted to make sure that everyone has a good understanding of how these initial history questions really impact how we're planning for surgery and how we're thinking and anticipating things that could go wrong during the surgery. So the first thing that I want to talk about is patients who have prior eye trauma. And when I say prior eye trauma, I'm mainly talking about like blunt trauma to the eyes, our baseballs, our pickleballs, and anyone who has an orbital fracture. Less so the penetrating traumas that are going straight to the OR, and less so like metallic foreign bodies that just needed a little scraper in the clinic. And the reason that these traumas are so important to know about is because of these zonules. So I'm just going to review a little bit of our basic anatomy here. So the zonules are the small fiber bundles that suspend the lens from the ciliary body and keep it in place in the center of the eye. So in this image, the brown circle is the lens, and there's 140 zonular bundles that suspend the eye. And when we're doing cataract surgery, we're making our little opening into the front of the lens, the capsular rhexis, and completing the surgery through that hole. And so the reason the zonules are so important during cataract surgery is we are moving that lens around so unnaturally. The phacoemulsification probe that we're using, all of our different instruments, we're really jostling it around. And so we need the support of the zonules to keep the lens in place so we can continue doing the surgery. And the tricky thing is with our pre-op evaluations is in real life, you can't see the zonules. They're covered by the iris. In cases of very severe zonulopathy, you can see something called phacodenesis, which is every time this patient moves, you can see that their lens is shaking. Again, this is very severe zonulopathy. This is not something that you would typically see in a patient who had like a mild zonular weakness after a trauma. And so that's why it's so important to have that, that in your history. So because it's not necessarily obvious during the pre-op examination, we have to be very kind of looking for signs of zonular weakness during surgery in a patient who has a history of trauma. So one of the first signs of zonular weakness during surgery is there you can see wrinkling of the anterior capsule when we go to start our capsulorhexis. The reason for this is not only are the zonules holding the lens in place, but it's also providing countertraction for when we are pulling on that front capsule. So if we don't have that countertraction, then when we start to make our capsulorhexis, the rhexis will just go out and out to the periphery of the lens, which should not be good. Other signs of zonular weakness during surgery could be excess movement of the lens during our phacoemulsification. So again, we're pushing on the lens with our probe, but if it's moving more than we would expect, that could be a sign of zonular weakness. And then full zonular dehiscence. So those zonules have just completely come off of the ciliary body, and you can see the lens has displaced out of the center of the eye. So this is an example of zonular dehiscence. You can see from 3 to 6 o'clock that the lens has moved up and out, and this lens is fully displaced. So what are potential problems that can happen during cataract surgery in a patient who has zonular weakness or zonular dehiscence? I mentioned the capsular tears already. So the capsulorhexis is running out to the edge of the periphery, and then you're at risk for that tear perpetuating to the back of the eye. And then you could also have a dropped lens, meaning the lens goes either through a tear in the capsule, or if there's significant zonulopathy and there's significant amount of dehiscence, the entire thing can just drop to the back of the eye. And they have to call Jay, and he has to come fix it. And we don't want that. Vitreous prolapse, this can either be from a tear, or if there's just significant zonular dehiscence, the vitreous can actually come through those areas of significant weakness. And then you have to think about your IOL placement. So typically we're placing our lens into the capsular bag, but if there isn't enough strength from the zonules, then maybe we can't actually put the IOL in the bag anymore. Actually, I saw a patient in clinic yesterday who was post-op day 1 after surgery, and surgery went totally fine. There was no history of trauma, and I'm going to examine him, and he has significant phacogenesis. And the patient was like, "Oh, like how long does cataract surgery last for?" And we were like, "Oh, it's a once-in-a-lifetime surgery, as long as this lens doesn't drop, because as long as the zonules remain strong enough to keep that IOL in place for the rest of his life. Hopefully he has no faults." Okay, so in this video, you can see right at the beginning, similar to the other photo, there's an area of zonular dehiscence from like 1 to 6 o'clock. And so this is going into how we manage zonular dehiscence, zonular weakness during the surgery. And I'm going to skip forward here. Because there is significant weakness, the surgeon is placing a capsular tension ring. And this ring is designed to work as a scaffold and create support for these areas of zonular weakness. And it basically disperses the weakness across the rest of the zonules. And this is something that stays in the eye. So this is going to be in the patient's eye forever. And you can see as this ring goes in, so it's going into the bag, that area of dehiscence where you could see the lens coming, moving out of the center of the eye is now gone. So the eye has now been replaced into its proper position. There are a few different options that we have for stabilizing the capsular bag in these situations. That surgeon used the first one, which is the full ring. There's also capsular tension segments, which are good if you have a more focal area of zonular weakness, probably less than 4 clock hours of weakness. And that's all. The segment also stays in the eye. And then the last option is a capsular hook. So this works very similar to like iris hooks, but It does not stay in the eye. It's something that stabilizes the bag temporarily, and then can be removed at the end of the surgery. Another common cause of zonulopathy can be our intravitreal injections. There's a very kind of ideal place to do our intravitreal injections, as many of you know. You don't want to be too far posterior because you'll hit the retina, and then again, you're calling J. And you don't want to be too anterior because you don't want to hit the ciliary body and you don't want to hit the zonules. So in our going back to that history, if a patient has had 40 intravitreal injections and like 30 of them were done by a third-year ophthalmology resident, you have to be on high alert for zonulopathy again. The next thing I want to talk about is past ocular surgeries. And specifically, I want to talk about patients who have had vitrectomies. So in the normal eye, there's sort of a balance between the pressure that's in the front of the eye and the back of the eye that's keeping the lens where it is. In a patient that has had a vitrectomy, and all that vitreous humor has been removed from the back of the eye and subsequently replaced with aqueous humor. And so when we're doing surgery, we're putting all these gels and viscoelastic in the front of the eye. And so the pressure from the front or onto the anterior part of the lens is actually much stronger than the counterforce from the back of the lens. And so what happens is the back of the lens or the posterior capsule can be much more floppy. And what that ends up looking like is, and this is a very severe case, you can see the edges of the rexus are very, very floppy. You can see them more so anteriorly here, but the fear during cataract surgery, once you have removed the entire lens, and you just have this unprotected capsular bag, is that the back of the capsule kind of flop forward and get stuck into your big old probe and subsequently cause a tear. And so you just have to be really careful in these cases. Maybe don't let your resident operate. The other thing that's important is the effective lens position of the IOL. Like I mentioned, the balance between the anterior chamber and the posterior chamber is a little different, which is why when we're doing our IOL masters, if someone is post-vitrectomy, we're putting that in because that changes the effective lens position of the IOL. The lens is probably going to sit a little further back than it would in a patient who is not post-vitrectomy. And so the more posterior effective lens position, you're going to get higher IOL power to achieve the same refractive target. Okay, the last thing I want to talk about is the medication list. There's so many things on the medication list that we're looking at. How bad is the patient's diabetes? Is this just like a really medically complex patient? Do we need to have them constant anesthesia first before we can operate? But the main thing I want to focus on for this talk is intraoperative floppy iris syndrome, or IFIS. Now, this is a condition where the iris has lost a lot of its tone, and because of that, it can create progressive meiosis, so the pupil becoming smaller, and the iris is moving around excessively during surgery, which can cause problems that I'll talk about later. Now, for pretty much all of our patients, I ask about if they've ever been on tamsulosin or Flomax, because that is a very common medication that patients are on, especially our elderly male patients. But there are so many other medications that are associated with IFIS. One of the strongest associations is with imipramine, which is a TCA or tricyclic antidepressant. And it's a less common medication that is administered. And so I'm not necessarily asking every patient if they've been on it, but when I look through that medication list, definitely pouring through for any of the medications that are on this list here. This is from a large retrospective study by Lakhani et al. And the pathophysiology of IFIS isn't very well understood for all of these medications, but this looked at associations between these medications and floppy iris. So this is just demonstrating a patient with IFIS who has progressive meiosis. And so you can see that as they're continuing to do the surgery, the pupil is just getting smaller and smaller. And I mean, this is sped up, but that's pretty dramatic. And that makes the rest of the surgery very difficult because now you can't see your capsular rexus. You can't really see as well what you're doing. There are several ways to manage this kind of upfront. But if you get to a point where you've already done your capsulorhexis, you are at this stage in the surgery where you're taking out the lens and the pupil is starting to come down, your options for management are getting quite limited. One of the other issues that can happen with IFIS is iris prolapse. So you can see that the iris is coming out through the main wound of the eye in this photo on the right. This is often because the iris is floppy, and also because of pressure changes within the anterior chamber. So if the pressure is too high in the anterior chamber, then the path of least resistance is for something to come out through the main wound. A lot of these will kind of just like pop back in if you just release some pressure from the anterior chamber and give it some time. And there are different instruments that we can use to kind of sweep it back into place. But what you don't want is the picture on the left where the patient has a large transillumination defect after surgery due to iris damage. Because patients on the left, they can have excess light sensitivity, they can have double vision because it's kind of acting like a second pupil. And if it's really bad, they might want to have an additional surgery for a pupilloplasty to repair that. So going into management options for IFIS, we can do some things medically. So a medication like Omidria, phenylephrine, and ketorolac, or just giving epi within the eye can help to maintain some of that iris tone so that it's not progressively coming down and it's a little less floppy. That's something that you can be prepared for, start to use at the very beginning of the surgery. If you have done a good history, you know that this patient is at high risk for IFIS, then you can consider using iris hooks or a Malyugin ring to keep that iris open. And there's pros and cons to this. The pros are that you are preventing this progressive meiosis, hopefully preventing some iris prolapse. The cons are that you are having to use another instrument, and this could cause some damage to the iris itself. Okay. That's all I have. If anyone has any questions, I'm happy to take them. But I hope that was insightful.
Questions? So, when would you have to use a Malyugin ring?
A Malyugin ring, yeah. So, oh, I shouldn't have stopped sharing. So, if someone has floppy iris syndrome, one thing that you'll often see before going to the OR is in the pre-op evaluation, they don't dilate well. And so, if you have a patient who is on tamsulosin and they also don't dilate well, that's a patient who you might want to consider putting in a Malyugin ring right off the bat.
Okay. Now, is it for pseudoexfoliation syndrome too? Explain for me that.
Yes, you can. So pseudoexfoliation has several different things that can happen with it. It can have zonulopathy, it can have pore dilation. So the capsular tension rings, the Malyugin ring, those apply to pseudoex too. Great. All right, thank you.
All right, our next presenter is Dr. Jay Wang. Please welcome Dr. Wang, who is completing his final year in his fellowship with us, Retinal Fellowship, correct? Jay has a medical degree from SUNY Stony Brook, where he also completed his ophthalmology residency. Before going into medicine, he completed a PhD in neuroscience at Albany Medical College and was a research scientist. During his training with us, he has proven himself to be a skilled clinician, surgeon, and we thank him for his mentorship to our residents and staff. Jay is going to be moving to New Hampshire to begin his career in private practice. Today, he is going to speak about intravitreal pharmacological treatment of AMD, diabetic retinopathy, and retinal vein occlusions. Please welcome Dr. Wang.
All right. Good morning, everyone. Thanks for the opportunity to allow me to give this presentation. So a lot of you know me, and for people who I haven't got a chance to work with, basically I'm here for 2 years for the vitreoretinal surgery fellowship, and had a great time here, learned a lot. So feel like a big family for me here. But anyway, for today's talk, I'm talking about anti-vascular endothelial growth factor therapy in retinal practice. So again, no financial relationship for anything to disclose for me. So the learning objective, we're going to talk about the current approved anti-VEGF medication, and mainly we're going to focus on the clinical value for three main arms: diabetic macular edema, retinal vein occlusion, and social complication plus neovascular AMD. We'll touch a little bit on the durability and treatment strategies for different medication. What we do, what's the long-term goal for those patients on those medication. And of course, we're going to talk about the intravitreal injection risk, complication, and losses to watch for those patients who come in routinely for medical treatment and injection. So regarding the anti-VEGF therapy, this has been available for the past 20 years, okay? So it's been pretty amazing to have those options for our patients. Before that, what do we do? Typically, we treat patients with laser. We can treat with the argon laser, which is a hot laser. You basically distract the blood vessel and treat the pathology. And when you do that, it's permanent damage. So you have to be very careful to stay away from the fovea. So you can treat pathology extra fovea with argon laser. The other option back then we also use often is a PDT, it's photodynamic therapy, the cold laser, which you can use to treat a subfoveal lesion safely if you repeat. But about like 20 or so years ago, starting in 2005, the anti-VEGF started to be available, and soon the whole community adopt. And basically, the anti-VEGF has been the mainstream for a lot of the retinal pathology instead of applying laser. PDT still has a role for very refractive pathology, but mainly the anti-VEGF, you can appreciate that on a daily basis in the retinal clinic. So the way it works is basically to reduce the vascular permeability and also to reduce neovascularization. I mentioned the main three things we treated in the retinal clinic: diabetes, vein occlusion, and also age-related macular degeneration is the white type. But also it can be applied for other pathology like myopia related choroidal neovascular membrane, or sickle cell retinopathy, retinopathy of prematurity, people who have radiation in the past may develop radiation retinopathy, can also benefit from the anti-VEGF medication. And we'll talk about the different pattern and strategy to apply those medications. You can do fixed pattern, you can treat as needed, or you can do treat and extend. Again, it's depending on individual pathology, individual patients. So no one is, there's no identical pattern to follow. But again, going back to the anti-VEGF, since when this was available and how we adopt this from oncology treatment to ophthalmology. So angiogenesis has been a main driven factor for tumor genesis. And I say probably back to 30, 40, 50 years ago, people have been thinking about how to limit or prevent even regress the tumor progression. So they target on the angiogenesis pathway. Eventually, people were able to develop anti-VEGF medication. So the image on your left side, you can appreciate for patient receiving anti-VEGF, this is mainly through IV, by the way, not intravitreal injection for sure. So basically, we target the tumor environment, also target microenvironment outside the tumor to block the angiogenesis, cause tumor shrinking, and normalize the blood vessel, and also make it easy for chemotherapy and also even cell like CAR cell can also be incorporated to be more effective to treat tumor. But regardless, when you look into the right image, which shows basically just an example here for age-related macular degeneration, the white type, neovascular age-related macular degeneration. So you saw RPE cell, and below that, that's Bruch's membrane, and down below further, that's choroidal capillaries. So often people with age-related macular degeneration, they can develop white AMD, meaning there's a choroidal neovascular membrane developed right around that layers. And those new blood vessels basically secondary to vessel proliferation, increased permeability, blood vessel migration. And those are driven by VEGF, which is a cytokine released by the local environment. So the anti-VEGF medication when you inject the vitreous cavity, they will target the VEGF pathway, and that can cause blockage of all those visual proliferation, migration, and the permeability to cause regression of the current neovascular membrane. That's basically, we learn a lot from the oncology folks, and we've been adopting this to the ophthalmology for the past 20 plus years. I think there's more to come. But this is a historical timeline, medication being approved or being applied to treat a retinal condition. So Avastin, the bevacizumab, which was initially approved by FDA, I think around 2004, to treat tumor, I think colon cancer. So the year afterwards, people in ophthalmology were, oh, actually, this is amazing medication. The same pathology happened in retina. We can give it a try. So they decided to inject Avastin to people's eyeball, and it worked phenomenally. So soon, around 2004, I think 2005, Myopia was approved by FDA as the first intravitreal injection anti-VEGF medication. But the initial design has flaw. It's a really big molecular. It's not really working as efficient even compared to Avastin. And soon after Lucentis, Retinopathy was approved around 2006. And eventually Myopia just being phased out from the market because it's not as efficient. Then we have Eylea, which is a different type of molecular. Oh, by the way, forgot to mention Lucentis is a fragments of antibody also targeting VEGF pathways, much smaller size compared to Avastin. You can compare these two. So Eylea is a different design. It basically sitting outside of the cells. They just gather and collect different cytokines instead of directly targeting on the receptor. We'll talk more about this. But time goes by. Now we have a Bellevue approved 2019, then Vabysmo, which is a bispecific antibody, we'll talk this as well. A few years later, then Eylea HD, which is really the same medication as Eylea, they just increase the dosage and the concentration. Again, this for like purely business market reason, they do this. So we can already talk a lot about those individual agents. So as I mentioned, Myopia was phased out. Actually, it was withdrawn from FDA approval in year 2025. Avastin remained being used off-label and never being approved by FDA, but every retina doctor get a chance to use it at some point. And in fact, nowadays insurance companies want patient to be on Avastin a couple of times before you can start with either Eylea or Vabysmo or any other biosimilars. So let's talk about DME. So diabetic retinopathy is a huge social economic burden across the world. And we do have patients come in with significant diabetic macular edema. This can occur for patients with non-proliferative type of diabetic retinopathy, which is on the minor scale of diabetic retinopathy. And the significant DME can be a huge factor for visual impairment. Look at this macula here, you can tell there's a lot of fluid and pocket within the retina, also sometimes below the retina. Surprisingly, I noticed the pattern for patients who only have fluid inside the retina, the intraretinal fluid, they tend to see okay. But once fluid starts to build up subretina, like you see this pocket over here, they can really tell the difference. But regardless, this has to be managed and treated, but otherwise, if you watch this long enough, the whole tissue will become atrophic. From really thick retina become paper thin, then things will never come back because all the tissue cells, they got lost. And a lot of medication has been approved. Pretty much everything under the sun for anti-VEGF is approved for DME. Typically, people can do really well as long as you come in to receive the routine treatment. So the recent approved medication, for example, Vabysmo, we'll talk about this, and also the Eylea HD, the high dose medication, showed a long-term duration and a better outcome compared to the traditional arm Eylea here. So the other thing we also offer to patients with anti-VEGF pretty routinely in clinic is patients coming in with retinal vein occlusion. Can be BRVO, HRVO, or CRVO, depending on how extensively the retina got messed up from RVO. It can be just a part of it, can be the whole thing. So for example, this image on the far left showed just a BRVO case. You see a segment of the retina is covered with heme, and there's some tortuosity, there's even some exudation coming to the macula and fovea. I can tell there's a CME developed here already just from looking at this from the photo. And the one in the middle showed a CRVO picture, basically blood center image from a significant central retinal vein occlusion, there's diffuse hemorrhage across the whole retina. There's a tortuosity. There will be often, almost 99% chance people will develop significant CME, and they will most likely develop neovascularization. So those two require treatment and intervention. And this is how the CME may look like in any setting of RVO. It can be BRVO, HRVO, or CRVO, regardless. They can develop similar picture as DME, but if you see this enough, you might be able to tell the difference, but they can look pretty much identical for the most part. Most of the agents belong to the anti-VEGF family have been approved to treat RVO-related CME. And I forgot to mention, those patients require like very early aggressive treatment. I think Dr. DiLoretto's protocol for new onset CME related to secondary from RVO, he would treat every month, 6 months in a row before slowing down the treatment frequency and regimen. So early treatment, aggressive treatment is associated with better visual outcomes in the long run. Last thing I want to talk is neovascular age-related macular degeneration. We have a lot of senior populations come into the clinic daily. Well, not daily, I mean, like every day we saw a lot of patients come in with wet AMD, and people require treatment. In the past, as I mentioned, they receive laser, either argon or PDT, but nowadays they've been on like anti-VEGF. So for macular degeneration, there are different patterns. Even the dry type macular degeneration, they can develop a significant atrophy called geographic atrophy. Like the image showing here on the far left, you can tell right below the fovea, there's a large part of the tissue loss. You can see all the brightness coming to the choroid, basically because the RPE, the photoreceptor, and the choroid vessel, they all become atrophic or gone. So I see a large like atrophic tissue here. And for the second image here, that's a neovascular AMD. You see blood accumulating below the retina and sometimes below RPE. So those are patients you have to treat aggressively before they develop this different scar, which is on the right side, meaning there's a large fibroblastic scar developed from likely a wet AMD at some point. At this stage, nothing you can do about this patient. Nothing will come back. So when you see wet AMD, you have to treat it very aggressively. And luckily, we have very good medication all the way from initial Avastin to Eylea, Vabysmo, and now there's a lot of biosimilars also being approved. And they can do pretty well as long you treat early enough and you monitor them frequently. So just another quick table to show like basically the high dose LEHD Vabysmo versus the previous well-established Eylea, how people can do with different medication. And typically, this basically just shows with LEHD or Vabysmo, people can do still pretty well even at light frequency injection like Q16 weeks, like one injection every 4 months instead of one injection every month or every 8 to 10 weeks. So yeah, now coming back, talk more about Avastin. So as I mentioned, initially this medication was approved to treat colorectal cancer back in 2004 with IV form, and someone really smart from Ophthalmology decided to adopt a year after to inject as intravitreal injection medication, still being used off-label, and a lot of places that pharmacy can compound this medication, and this is very affordable for patients. So that's why insurance company they kind of push for initial treatment with Avastin first, a couple times, then eventually can bridge into more brand name like Eylea or Vabysmo down the road. So Lucentis, as I mentioned, this is a fragment of the antibody targeting VEGF-A. It's a smaller size, being approved for like pretty much everything. And it's been working really well, but again, it's kind of on the expensive side, but not as potent as later players like Eylea or Vabysmo. So we don't really see this too often, but some patients, they do well, on Lucentis, they don't want to switch. And we have, for example, patients develop antibodies to either Eylea or Vabysmo, then you can switch back to Lucentis, see how they respond clinically. So it still has its value in retinal practice. And also, I believe for ROP patients, this is the one being approved. So often for patients with retinopathy of prematurity, Lucentis is the one we treat with injection. Eylea, so this is one of my favorite medication. I don't know why, but this is a molecular antibody basically stay outside of the cells. It basically trap VEGF-A, VEGF-B, and also placental growth factor to block the pathway from those all the way to the receptor and downstream to trafficking kinase. So it's really potent medication and works wonder. And I think this has been on the market, dominant market for like quite a few years, almost 10 years before Vabysmo start to emerge and take out some of the share. But regardless, they also have ADHD with same medication. They just make it more concentrated. Again, trying to fight for the market with Vabysmo. So Vabysmo, this is a bispecific antibody, meaning it got two targets. The one arm targeting the VEGF-A pathway, the other arm targeting the angiopoietin-2, which is a molecular can be a strong driving factor to cause vascular permeability and migration. So when you block angiopoietin-2, you enhance the stability of the blood vessel. And on the other hand, with blocking VEGF-A, you have the traditional arm to also inhibit angiogenesis. So this is a pretty strong medication. I would say clinically, anecdotally, I feel this is stronger than Eylea. Sometimes way too much can dry the tissue too fast, can cause problems. So I'm a little cautious about offering patients with Vabysmo myself. But it has been approved for like basically the three arms we talked about: DME, RVU, and neovascular AMD. And this is really strong medication. That's why people can be on this medication with much less duration, frequency for injection can be extended all the way to 4 months. So patients do appreciate that, less injection. So Bellevue, I like to just mention this because it does have its role for neovascular AMD. It's been approved only for that indication. This one in the past has been associated with some retinal vasculitis and also retinal vein occlusion concerns. So it still has its role and function, but I don't really see this medication being used often. Some patients being on this, they're doing well, so we just keep them on the medication. But often, this is not the go-to medication nowadays, I believe, for AMD. So when you have patients come in, require treatment, of course, you have to do the systemic review and figure out the baseline, look at their other ocular pathology or systemic problems, then you figure out what works best for that patient. That patient can come in like routinely, or they require transportation, or they may have like other medical issue, they cannot be here often, and also their insurance. A lot of things you have to think about before you make the final recommendation to the patient. Because those patients, if they need to be on anti-VEGF, they need to be on this for the rest of their life. So you have to be careful to figure out what works best for the patient. I do want to touch base with all the post-injection complications. This is more important, in my opinion. A lot of things can happen to the patients. I mean, I got caught often, like late night or during the weekend, patient had an injection 1 or 2 days ago. The doctor, I still have blurred vision, I still have pain. In fact, a lot of pain. Never goes away, never get better. Okay, come in, let's take a look. So the common ones, the less concerning ones, typically patient will experience foreign body sensation. Again, from the injection itself, from the prep, we do apply a betadine to clean the surface to make sure it's a sterile procedure. And that can cause cornea and also surface toxicity, can cause a lot of irritation. And once in a while, you do have patient come back with corneal abrasion. This can be from when you apply the speculum to keep the eyelid open, that can cause cornea scratch, and also can happen when you remove the speculum. So be very careful when you do this. We'll start with the injection to avoid giving patient corneal abrasion. And subcorneal hemorrhage is typically, you expect this is very high, highly likely to occur. But as long as patient has no other symptoms, this will go away. People may also say, doctor, I see a black spot after the injection. That's typically air bubble being introduced to the vitreous cavity during injection, but they may see other floaters. Blurred vision can last from a couple hours, couple of days. So those are okay, tolerable. Those will go away. Artificial tear, cold compress, a lot of things can help. But there are also most serious concerning complications from intravitreal injection. Number one is endophthalmitis. There are different studies, papers, they look into the rate of endophthalmitis post intravitreal injection. It's run from 0.01 to 0.06. So I just took, I'd say 3 patients out of 10,000 injection, people may come back with infection. And the one being a fellow here, I think I managed 10 to 15 cases. Patient basically came back with endophthalmitis post-injection, either from this practice or from outside community providers. So the other complication is retinal detachment. I haven't seen one here, which is great, but this can still happen. During the injection, somehow this can still cause wrong spot, or even the injection itself, the medication, everything can also change the vitreous. There may be a new PVD, there could be a retinal tear followed afterwards, eventual detachment. So that can still be a risk factor. Traumatic cataract, I think Dr. Joseph just mentioned about this. When you're not looking carefully, you inject to the wrong spot, you may touch the lens, you can cause traumatic cataract from the injection. And pressure spike. So this is more common and sometimes can be very concerning when patients have known glaucoma history. So for example, a patient come in, you saw, oh, there's a bleb, there's a plate in the cerebral temple. Number one, stay away from that cordon. Do not inject the bleb. Number two, be careful. Please check the pressure before the injection. Make sure it's not exceeding high. Patient come in with 40, 50 IOP, you should not inject. If you really want to, you do AC tap. But yeah, pressure can spike a lot. Typically with routine VEGF, it's 15 microliter. It should not cause too much. But again, the pressure elevation post-injection is not a linear fashion. It can, when up certain threshold, it can spike up a lot. Intraocular inflammation is not always common, but when it happens, it can be very confusing, meaning either the medication or the procedure or the prep can cause inflammation inside the eye that can be misleading towards endophthalmitis. So you have to be very careful, either you see hypopia or not. You have to think about both and treat aggressively. Steroid, topical, but also you want to cover the potential infection, put patient on antibiotics at least. And retinal vasculitis, which is not so common, mostly with Belleville has a higher reported rate, but for the most part, we don't see this too often nowadays. And the other thing is arterial thromboembolic event. I never seen they talk about it, so I don't really know too much about it, to be honest, from injection. So as I just mentioned, injection is not totally benign. It's the most amazing, in my opinion, advancement for ophthalmology field for the past 20 years, but it does not come as a benign procedure. So make sure you do everything as thorough as you can, and just make sure a patient come in is ready for injection. If they have an ongoing inflammation, infection, really poor hygiene, just skip injection, please. Ask patient come back in a week or two. Make sure they do really good warm compress, clean the eyelid, make sure they're ready. If they have chalazion, which is the inflammation, but it can still be a risk factor infection, ask patient come back. There's no need to rush. Educate the patient so they know what to expect from injection. Blurred vision, redness, bleeding, floater, and mostly concerning persistent visual acuity drop, worsening pain after injection. You do not want patient to wait on themselves for endophthalmitis to incubate. Otherwise, just watch for everything, pressure, inflammation, and as patients coming along through the treatment, you see how they do. You tailor the regimen depending on the insurance. You look into different options, so you can help them. And yeah, so basically, I hope from this talk, you learn a little bit from me in terms of what's available in the market to treat retinal problems, specifically DME, RVO, and AMD with anti-VEGF medication. And what's the indication, what's the neuro medication, specifically first map, which is Vabysmo, and also Eylea HD with prolonged duration. And most importantly, the complication from injection, what to look for and what to offer to the patient for education. And there are a lot of things being actively studied for, trying to, I guess, replace those routine injection. You can put a port, you can do gene therapy, you can do cell therapy, a lot of things being actively worked on. I think in the next 5-10 years, we'll see something new coming up. So hopefully we do not have to put a needle into patient's eye every month. So I think I will stop here. I'll take any questions.
Any new developments where you'd be able to deliver that medication without use of a needle?
Yeah, I mean, Gentech had this port delivery system, which actually was approved quite a few years ago. And it was concerning for basically what they do, they put a port, like when you do the vitrectomy surgery, you insert a port through the conch, pass steroid into the vitreous cavity. And with that port, you can just deliver the medication when needed, instead of poking patient's eye every 4 or 6 weeks. But the initial design has some flaw, and there's erosion, and there's social infection. So it was on the market for a while, then physicians start to stay away from that because of the concern for complication. But I think they tuned the system, now they show better safety design. So I think a certain part of the country start to welcome it back.
Thank you.
Yeah, Peter.
What about intravitreal medications like Izervay for geographic atrophy?
Right. That's another. So Peter mentioned the newer medication being approved for the past 2 to 3 years, mostly for dry AMD. So those medications are not in the same arm as anti-VEGF. So those are not anti-VEGF medication. Those are complementary factor inhibitors. So they target specific different signal pathway. Mainly the goal is to slow down the progression of geographic atrophy. I personally am not in favor of those medication. I do not really think those clinical evidence are strong enough for me to persuade my patient to do it. Unless patient got a really good education, they're so committed. Otherwise, yeah, I'm not a big fan yet. Yeah. No, not yet. I don't think so. The port delivery system is one way, but there's no specific implant. So they look into gene therapy. So they want to basically inject like viral factor based medication to the back of the eye. In this case, those tissue got the viral integrated, and they can produce certain factors to basically perform in the same way to block the VEGF pathway. So those could be long-term plan, but it's still under active investigation. It could be approved at some point. We'll see. The other thing I forgot to mention is the downstream pathway, the tyrosine kinase. Nowadays, they also look into newer medication just blocking the downstream pathway of the tyrosine kinase inhibitor. The results from what I saw, again, we'll see. I'm not so optimistic myself. I'm very skeptical. Any other? Yes.
How do you feel about some of the new simulators available?
Yes, for sure. Actually, I think Dr. Narayan and Dr. Tan will
Talk in the afternoon.
talk about similar this afternoon. So I will save most questions for them. But a lot of biosimilar being approved recently is a huge market. That's why a lot of companies want to jump in to take the market share. I think no, biosimilar has value and supposed to behave the same way, but not necessary. Yeah, it's a. I'll wait for them to talk more about it. Yeah.
Okay, I know it mentioned about transient floaters, but there's people who have already had posterior vitreous attachment.
Yes.
So is that going to, because I know that the PVDs can come in stages, would that make it?
Not necessary. Typically, the transient floaters is something not directly associated with posterior vitreous detachment of the vitreous itself. Often people see bigger 1 or 2 floater, that's the air bubble being introduced during the injection. And people may see some floater, transient floater also because the medication being placed into the vitreous cavity has certain viscosity. And when it is dispersed into the vitreous cavity, it can give patient symptom for like a few hours. But those typically settle down if you give them some time.
So they kind of go away?
Typically they go away, yes.
They do?
Yeah,
Okay.
yeah. Mhm.
Thank you.
Yeah, of course.
Thank you.
Thank you, everyone.
So I'm going to be presenting Seeing the Future Clearly, Myopia Management in Focus. So we're going to focus on myopia management. Just a little background on myself if you haven't worked with me in clinic before. As he said, I am from Nebraska, so I graduated from the University of Nebraska. And then I did optometry school in St. Louis, and I did a cornea and contact lens residency at The Ohio State. I facilitate the medical contact lens clinic here at the hospital location where we fit scleral lenses, which is what you see in this picture here, in addition to corneal gas permeable lenses and prosthetic lenses, all for the purposes of visual rehabilitation of various patients. So today we are not going to be discussing specialty or medical contact lenses. We're going to focus on something else, but this is one of my favorite topics. Today, we're going to be focused on nearsightedness or myopia. So we'll start off with what is nearsightedness. I realize there's various levels of experience within this room. So a lot of individuals are like, oh, I know what myopia is. It's very easy for me to define. However, some of us may be newer to the ophthalmology world, and it may be a little bit more difficult to define exactly what nearsightedness or myopia is. To start off, nearsightedness and myopia, same thing. They mean the exact same thing. So some of you may tune out during this beginning portion of the presentation. Please try to stay engaged. I'll try to make it as exciting as possible until we get to the kind of the meat and potatoes of the presentation. We'll start off by defining nearsightedness or myopia so that we're all on the same page. So nearsightedness is essentially a refractive error in which light enters the cornea or the eyeball itself parallel, but comes to focus in front of the retina. So what you see here is a very crude image of an eye that I drew myself. It is an eyeball as if you slice it in half, and we are looking at the side view of it. So that curvy structure that you see at the front, that's your cornea, and the light is entering parallel, and then the light is coming to a focus on the very back of the eye or the retina. This is what a normal eye looks like, or an emmetropic eye. This enables them to see clearly, and this is the goal I would say for all patients, we want the light to come to a focus on the retina so you can see well. However, if you are nearsighted, that's not what's happening. So the light is actually coming to focus in front of the retina. Now, what causes this? It can be typically one of two things. One, the eye itself is actually physically too long. If that's the case, we typically refer to that as the axial length, or the length of the eyeball itself being too long. The light is always going to come to focus in front of the retina, and that patient's not going to have clear vision. So that could be one cause of it. The good thing is we can measure axial length. The testing technicians here at the hospital are great. They can measure the axial length for us, and we can calculate the nearsightedness of the eyeball based on that. Another cause could be that the cornea, or that front surface of the eye, is actually too steep. If the cornea is too steep, or the keratometry values are too steep, the eye itself is going to be too strong. So that light is going to come to a focus in front of the eye. Now, as I alluded to, we can measure this as well with a keratometer, a topography, and oftentimes your autorefractor will also give you K values. Those K values can indicate the power of the cornea, and that can also help us to determine nearsightedness. Okay, but what do we do about it? So now we know what it is, we know why it happens, but what do we do about it? There's kind of two different schools of thought here, two different methods we can go about. But I always say they're not mutually exclusive. So they often act in tandem, where we need both of them to really successfully treat nearsightedness. There's the traditional aspect, which is correction, and then there's myopia management. So we're going to talk about both of them. To start off, we'll go the traditional route. So correction, this is what we typically think of. These are glasses, these are contact lenses. These are great because they're going to help that light focus on the retina. However, they are not going to do anything to slow the progression of the nearsightedness. They're going to enable that patient to see really well when they're in your chair, but they're not going to do anything for next year, meaning their prescription may change. I always point out, because I think a lot of patients ask us, is wearing my glasses or wearing these contacts, am I going to make my eyes worse? Absolutely not. That is a myth. So I always tell patients, please wear your glasses. You're going to see so much better if you just wear your glasses. But like I said, this doesn't do anything to slow progression. So do we have any options out there now that can make it so our prescription doesn't continue to get worse? Absolutely. That's where myopia management or myopia control comes into play. Now, myopia management and control are truly the same things. Different offices will utilize different terminology, but essentially means the exact same thing. However, this terminology, it sounds kind of fancy. What exactly does that entail? It entails a couple different things, and I always describe it as kind of a three-pronged approach. One is early detection, 2, correction, and 3, control of myopia progression. So you really need all of those things working together in order to successfully perform myopia management or control. And if you notice, correction was part of that. So like I said previously, we don't just do correction. If we do myopia management, it encompasses the correction. What the true management portion is ongoing monitoring of these patients. And so we utilize evidence-based interventions to slow the progression of the myopia, but it also requires us to see these patients more often in order to essentially assure that their myopia isn't continuing to progress. There are various modalities available for myopia management, and that's what we're going to cover today. The topics that we're going to cover in the myopia management space are the topical eye drops that are available, the spectacle lens that's available, a daily disposable contact lens, and also a gas permeable contact lens. We are going to start off with the only topical, or really the only medication option available within the myopia management space, and this is atropine. Now, I know you can see this picture here and has a nice red cap on it. Does anyone recall what a red cap indicates? Oh, good. I figured you guys would know that one for sure. So atropine, or low dose atropine in this case, has been shown to slow myopia progression in children and reduce myopia related axial elongation, which is the lengthening of the eyeball. However, it is not FDA approved and it's often prescribed off label. You have also notice I said low dose. So these are not traditional doses of dilating drops that we think of in the clinic. This is more like 0.05%, 0.1%, very low percentage dilating drops. So they have to be compounded in pharmacies, meaning made specifically for the purpose of myopia management. And so we have to send it to a special pharmacy. It's a bit of a process, but we do have one that we work with here at the university. And it does require that patient to continue to wear glasses, meaning taking this eye drop is not going to make it so you don't need glasses at all. It does require you to wear your glasses during the day. Oftentimes, this is an eye drop that the patient's going to put in right before bed. And just once a day is all they would do. And then the percentage that we prescribe depends on the prescribing physician and what they think is going to be best in order to prevent progression. Now, as you guys pointed out, this eye drop is a red cap, so it should dilate the eye. But is that really how it's preventing the myopia from progressing? Well, the answer is yes and no. It acts through a non-accommodative pathway, meaning independent of the near focus, and it modulates muscarinic receptors in the retina and sclera. This in turn influences scleral remodeling and choroidal thickness, slowing eye elongation. However, there has been some debate on if that is truly how this works. So it's still kind of out for debate, I would say. People are still discussing, we're still doing research, but it has been proven to be effective in slowing the axial length growth associated with nearsightedness. Next, we're going to discuss kind of the latest and greatest in this space, and that would be the spectacle lenses that are specifically for myopia management. This is the Stellus lens by Escalate. Now, this lens is FDA approved for myopia management, meaning slowing myopia progression. So that's great to tell parents. They often feel reassured when we tell them this is an FDA approved option because that implies there's been a lot of testing done on it. We know it's effective. But how does this one work? Well, centrally, if you can see in this picture, it's nice and clear. And then it's surrounded by these little dots. They refer to these little dots as lenslets. And what these lenslets do is they create a controlled blur, essentially making it so the patient can see clearly centrally, but then these lenslets are creating a mid-peripheral blur. What that does is it creates a myopic defocus in the periphery. So if you think back to the pictures that we talked about, and the light was coming to a focus on the retina, that's still what's happening centrally here. So the patient is still seeing really well. But then in the periphery, what's happening is it's actually making it so it comes to a focus in front of the retina. The concept there is, or the thought, if we focus the light in front of the retina in the periphery, there shouldn't be any signal for that retina to further elongate, meaning slowing axial elongation, slowing myopia progression. That's the thought behind it, and it's been proven to work, so that's exciting. And I would say the added benefit here is patients, they typically have to buy a pair of glasses no matter what we're doing. I always tell the parents, well, if you do the atropine, you need glasses. We do contact lenses, you need glasses. We do nothing, you need glasses. So this is a great option because not only does it offer these patients correction, but it's going to actually have some proven benefits to slow the myopia progression. The biggest drawback, it's considered like an upgrade, meaning your insurance benefits sometimes don't apply to these lenses. So there's a large out-of-pocket cost for patients. It also typically requires you to come back for a follow-up because we need to make sure the glasses are fitted properly. Because if they're not, these lenslets could cause a problem. So it's more on the parent's part, but if it could prevent your child from becoming more nearsighted in the future, it might be worth the investment. Now we're going to get into some of the contact lens options. These are my favorite. So we'll start off with the daily disposable soft contact lens specifically for myopia management. This is the MySight One Day Lens by CooperVision. This picture here we'll start off with because it essentially explains exactly what I was trying to describe on the other slide, where the light is coming to a focus in the center, but then in the periphery, you have that myopic defocus. This lens works similar to the glasses lens. However, no fancy lenslets here. It's just concentric rings. So centrally, that light comes to a focus on the retina. Great, patient can see really well. And then in the periphery, that myopic defocus to prevent axial elongation because there shouldn't be any stimulus for the eye to grow if it's focusing in front of the retina. So these are great for kids because one, they're FDA approved. Parents love to hear that. But two, they're daily disposables. Kids don't tend to be the most hygienic creatures. And so it's really nice to be able to just toss the lens at the end of the day. Or if for some reason they lose it at school for what, maybe they're really rubbing their eye or something, you get a new one the next day, don't sweat it. So I think that's a great option, as well as it's going to prevent any sort of infection associated with extended contact lens wear. So these are a great option for active kids who maybe glasses aren't suitable for playing sports, but they want the myopia management aspect. And then the final contact lens option we will discuss are gas permeable contact lenses that are specific for myopia management. Now, I typically really try to avoid the word rigid, especially when I talk to parents, because rigid sounds very uncomfortable. So I typically just say a firm contact lens, a contact lens that holds its own shape, because I don't want them to think I'm putting like a rock in their child's eye. These contact lenses are specific for myopia management, and they're referred to as orthokeratology lenses or vision shaping technology lenses. Now, if you work with Dr. DePaulis or you work with Dr. Ryan, you've heard of VSTs before. I don't typically use that terminology. I stick with orthokeratology. So that's what I'm going to refer to them as, but they mean the exact same thing. So just know we have different names for the same thing. These lenses are essentially the opposite of what we typically tell patients. So when you're doing a contact lens insertion and removal training, one of the first things that you tell your patient is do not sleep in the lenses. These, we tell them the opposite. We're like, you're going to take this lens, you're going to put it in right before you go to bed. Don't try to do anything with your eyes open, because most of the time they're kids. And to be honest with you, at first, it's not the most comfortable. So I usually say, put it in, go right to bed. Don't do anything else, which is the opposite of what you tell a patient who's going to wear a daily soft contact lens. You say, take that thing out before you go to bed. Whatever you do, don't sleep in it. And so with this lens, patient puts it in before they go to bed and they wake up, they take it out. Great. Do they need correction during the day? If it's functioning properly, absolutely not. What this lens does is it temporarily reduces myopia. It does so by centrally flattening the cornea. So if you recall from like the very first beginning of this presentation, we talked about there are kind of two causes associated with myopia, one of them being the cornea is too steep. So if I flatten the cornea, I can temporarily reduce the nearsightedness of that eye. And so that's what this does. It's also a very similar concept of what LASIK does. So sometimes I call it temporary LASIK because eventually it's going to wear off. However, this process of flattening the central cornea has to be done pretty darn precisely because that lens is not actually landing on the cornea. So if you look at this image here, this is an orthokeratology lens inserted with sodium fluorescein dye. And what that enables us to do is see areas where the lens is flatter and see areas where the lens is steeper or there's more space. So if you see right over the pupil there, you don't really see a lot of green. That's where that lens is pretty flat. It's not actually touching the cornea, but it's flattening it. It's flattening it by inducing forces that cause the epithelium to move. What that does in that area where you see all that green, that's an area where the lens is steeper. That's where we're going to push all that epithelium. So we're not actually taking it away. We're just pushing it. We're redistributing. What this does is it creates central flattening, reducing the myopia, mid-peripheral steepening, which causes that myopic defocus and is used for myopia management. However, this is not FDA approved for myopia management. It's FDA approved for the correction of myopia. And it does that very well. It just has an added benefit of having myopia management aspects to it. It's only temporary. So if your patient discontinues wear or misses a night, oftentimes their vision's going to be blurry the next day. So they just put the lens back in the next night, it goes back to what it was before. It does take some time for these patients to get to a place where they are achieving what we call the full treatment, meaning we're correcting all their nearsightedness. But as long as they're willing to stick with it and they're motivated, which a lot of times a child is motivated by mom and dad saying, put the lens in before you go to bed, or you're not going to get some sort of toy or prize or dessert. So that's helpful. I would say these are very popular amongst patients who are very active. So a lot of children who participate in water sports, this is great because they don't wear anything during the day. So diving, swimming, water polo, this is one of the first things I recommend. Even if they're not interested in myopia management per se, this is a great option that alleviates their need for glasses during the day or contact lenses. Now, we know all these options, but do we actually need any of them? Like we've been correcting nearsightedness with glasses and just traditional contact lenses for a very long time. So why do we need any of this new stuff? Well, I would say that comes down to how common nearsightedness is. For adults in the United States, approximately 30 to 50% of individuals are affected by myopia. It's a pretty good portion of the population. As far as children and young adults go in East and Southeast Asian countries, myopia has reached epidemic levels. So over 80% are myopic by the end of high school. That's a huge group of young people that are now nearsighted. And then in the future, by 2050, they project that 5 billion people, or 50% of the global population, will be nearsighted. And around 10% of those individuals will be highly nearsighted. So that's an even larger group of the population. So not only do these people need glasses then, they might need something more than glasses. I want to start out with just this image that you see over here because it does a great job. I don't say any of this to scare anyone who's nearsighted in the audience, but being nearsighted increases your risk of a lot of ocular complications, meaning I would say the least severe being a cataract, because we see cataract surgery all the time. Cataracts can be successfully removed. I would say the more scary things are on the other end of the image: glaucoma, retinal detachments, or myopic macular degeneration. So if you're greater than a -6, you're considered severely or highly nearsighted. You are 14 times more likely to develop glaucoma, 22 times more likely to experience a retinal detachment, and 41 times more likely to experience myopic macular degeneration. These are all sight-threatening conditions. And we are all in the business of preserving eyesight. So because of that, I think it's very important that when we consider that 5 billion people are going to be nearsighted, and 10% of those are going to fall in that 41 times more likely, that 22 times more likely, we should probably educate our nearsighted young patients on these options that exist, because we don't want them to get to that point. That's where the early intervention comes in. We don't want you to end up with being a -6 because we don't want you to have a retinal detachment. I mean, we can do something about it, but we'd like to avoid it altogether, I would think. And like I said, I don't say any of this to scare you. I think it's important because I am a -10. And I would have liked somebody to sit me down and say, you could wear this contact instead of the one you're wearing, and you might stay a -3. And then your odds decrease by a lot. And we have the technology now, we have the means. And so I think it's important that we educate patients, and you guys can play an important role in that, not only just working up patients, but I mean, we have materials that we hand out. You can bring things up to the provider. I know we don't want to step on any toes, but it's important that patients know that these options exist. And that's it. Does anybody have any questions? Yeah, go ahead.
For a kid who's actively growing,
Yes.
and their myopia is increasing, like, do you have an average age, or do you wait till they reach a certain point to start the myopic management?
I will start it in anyone who shows any signs of progression, more so if you have a family history of high myopia, because we know that those kids are more likely to progress. So even if it's just one parent that's highly nearsighted, you're more likely to progress. And so I'll start it in anybody who's interested. But if I see marked progression from year to year, those are individuals that I'm going to hand a pamphlet to. I'm going to say, we have these options now. I want you to consider it, even if it's not this year. This way you can plan, because they all are kind of, unfortunately, they're a little expensive. So sometimes you have to plan one year to the next to save up the money so you can do it for your child next year. But I want you to know that we have these options here. Yeah. Go ahead.
Treatment.
That's a good question. There's kind of a large debate on when do we stop treating nearsightedness? Like, when do these methods when do we discontinue? Because nearsightedness has been shown to progress even in college age individuals now, because they do so much near work. So we have a couple patients who are in their early 20s, and they're still doing their myopia management because it's not hurting them. Eventually, a lot of times college kids get to the point where they're like, I don't sleep enough for ortho-K lenses, or I don't want to keep doing this eye drop. And that's when we'll talk about discontinuing. But until then, we continue. And I would say by the time you're 30, it's very feasible. We can stop. We don't need to keep going. But if you're going to continue studying all the way up until you're 30, I would say let's keep going.
Thank you.
Yeah. Go ahead.
Do you have a preference between the study eyeglasses and the MiSight contact lens?
I think it's really dependent on the child's activities and the parents' willingness to be involved. If you are wanting to be as hands-off as possible, I almost always say, okay, let's do the glasses, because that's going to require less monitoring on the parent part, I feel like, because it's just, you do have to make sure your child wears glasses, but you're going to do that anyway. Versus with contact lenses, sometimes you have to be more involved with initially putting them in, taking them out, and taking care of them. Also, typically more follow-ups involved with those visits. And so we discuss that all before we kind of pick a plan for the child, and make sure that they understand, like, this is what you're committing to. This is going to be so many visits. And if they're okay with that, then we move forward. Yeah. Go ahead.
Yes, permeal lens, the overnight lenses.
Yes.
As the day goes on, does your cornea go back into shape and the vision gets blurrier?
Yes, that is exactly what happens. So there's a certain amount of overcorrection that takes place, and that is supposed to encompass the kind of rebound that you experience during the day. Oftentimes those patients towards, like, if they come in and see me at like 4 o'clock, I'm usually not very happy to see them. I would like to see you early in the morning because I want to know exactly how much treatment you're getting out of your lens, versus if I see you at 4 o'clock and you're a little blurry. That's kind of what I would expect. Most kids are pretty tolerant. So if you come in at 4 o'clock and you're 20/25, I'm not going to sweat it. Yeah. Go ahead.
Is there a minimum amount of hours that they have to sleep for the ortho-Ks?
Usually we recommend 6 to 8 hours, which doesn't seem like that much, but college kids sometimes will be like, I slept 2 hours last night. And so those are like the kids that are like, no, we don't want to wear this anymore. But I will say, this is just like a little ortho case secret. So they will discover that they could wear the lens for 1 day and go 2 days, or they could wear I don't recommend it, but they always discover it on their own. And so there is, the longer you wear it, the longer the treatment is sustained typically. Yeah. Go ahead.
So you have to sleep in the ortho-K lenses. Is there like the same risk of infection as like a regular lens?
That's a very good question. There is an increased risk of infection associated with ortho-K wear if you are not managing them properly. So it's very much important that those patients understand, one, the signs of infection. So if your eye is red or irritated, absolutely no lens wear. And then also making sure they understand, like, these cases, we got to throw them away. If we use any devices to help us insert or remove, we're going to clean those. Solutions we dispose of in a timely manner, and then always washing our hands and that kind of stuff. Yeah. Go ahead.
The overnight lenses.
That's a good question. On average, we tell patients to plan on replacing the lenses annually. That's what's recommended. However, the older patients tend to take better care of their lenses. And so some of them are able to wear the lenses for like 2 years or even 3 years. But after that, we're like, no, you need to get a new one. It is a piece of plastic, and over time, just like your glasses, it gets scratched, coatings wear off, and it needs to be replaced. Yeah, go ahead.
Lenslets work by blurring the vision and like stopping the light signals from reaching the retina as clearly.
Yes.
Like stopping myopic progression.
Mhm.
Wouldn't that suggest that correction itself like promotes myopic progression?
That is a good question. So that is part of the theory behind it. By focusing or giving myopic patients almost their full correction or too much power, you're essentially introducing like hyperopic defocus in that very far periphery. And that's the theory behind defocusing in front of the retina. So yes, essentially. But that doesn't mean myopic patients should not wear their glasses. We get into like a hairy situation there where if you tell a nearsighted patient, oh, don't wear correction, then are you going to induce amblyopia by telling them to walk around uncorrected? I think that would, you kind of have to choose the lesser of the two evils there. Yes. Yeah, go ahead.
Is there any risk of increased pressure with using, like, flattening the cornea through the overnight lenses?
There is no evidence that wearing ortho-K lenses increases the eye pressure, and it's only, I would say, because they're fitted properly. you're not actually landing on the cornea anywhere. It's actually a hydrostatic pressure that's created by redistributing the corneal epithelium. So because of that, there isn't actually, like, there's not really any suction or anything when you're putting them in or taking them out. So it doesn't increase the eye pressure. Yeah. Anything else? Are good? Okay, perfect.
Okay, our next speaker is Dr. Ella Arnon, who is an assistant professor of ophthalmology at the Flama Institute, where she divides her time between the urgent eye clinic and ocular genetics service. She offers advanced diagnostic imaging expertise that is unique to the region, playing a key role in evaluating complex and rare retinal conditions. Dr. Arnon earned both her undergraduate degree in health science and her medical degree from Technion, Israel Institute of Technology. She completed her internship at Carmel Medical Center and her ophthalmology residency at B'nai Zion Medical Center in Israel, where she earned board certification in ophthalmology. Her passion for retinal disease led to Duke University Medical Center, where she conducted research about artificial intelligence to predict the progression of retinal conditions. She went on to complete her fellowship in inherited retinal disease and medical retina at Boston Children's Hospital before joining us. All right, and so please welcome Dr. Arnon as she presents Don't Blink, See It, Spot It, Escalate It.
It's getting very good. I'm an app. I'm working in the eye clinic. I have my own clinic, and I'm doing some electrophysiology. And I want to ask you a question. How many times you got into a room, you saw a patient, you saw red eye, and you said, just red eye, it's simple, it's nothing? Raise your hand if you saw such a case. Never entered into a room and saw red eye? Oh, yeah.
Yeah.
So today I'm going to talk about things that are not simple, that are urgent, that are serious. So your role as a technician, you are the first one to see the patient. You can spot severe signs and you can contact us, and together we can prevent vision loss. Never ignore red flags. And now we'll talk about red flags. So it's just a game. We're going to play a game. We are going to learn, but there will be a winner at the end. And there is a prize. So what is important in order to be an outstanding technician? You have to do good documentation, good communication, teamwork, empathy, attention to details, and escalation. If you see something that is worrisome, tell us, because patient might lose his vision, okay? So now the program, you can scan it. It will ask you to put a name. You can insert your name. You can insert nickname, whatever you prefer. No significant ocular history. Present with 10 hours of progressive left eyelid swelling. He reports pain, tenderness, warmness around the lid, blurry vision, difficulty moving his eye, and he has recent sinus infection. What is the most concerning diagnosis? Hello. Good job, guys. Patrick. Okay, Patrick, can you describe what you're seeing? Patrick, what do you see here?
Redness, swelling, saggy eyelid, probably goopy.
It's not just that it's swollen and red. the eye is actually bulging out. I mean, different location. Yeah, this is very concerning. This means that the infection already got into the orbit. So orbital cellulitis, red flags, blurred vision, decreased vision, painful or restricted eye movements, proptosis, fever, and it's emergency because people can lose the vision. And also people can die. It can get into their brain and they can die. So it's very, very serious. Ready for the next one?
Yeah.
Okay, 43-year-old man came with 4 days of ocular pain, discomfort. There is some rash involved the nose. What is the most likely diagnosis?
Rash. Okay, I devised that.
Just gotta wait some time.
Oh, okay. I already know what it is. I already know.
I don't know anything. I haven't done. Do that.
Good job. Wow. Okay. Okay. So let me now, I'm going to describe it because it's going to be, I want to ask you all the questions. So we need to be a little bit faster. So here I see patients, yes, some rush, looks like vesicles. It involves the eyelids, the upper and the lower one. There is some swollen eyelids, redness, and all the vesicles, and it's just in one side of his face. No question.
Cranial nerve 5.
No question. Okay, so ocular pain with vesical rash that involve the nose. The nose is very important because if it involves the nose, most likely involve the eye, and there might be keratitis, inflammation of the cornea, uveitis, inflammation of the anterior segment, and also it can cause elevated eye pressure. It's called Hutchinson sign. And it needs urgent evaluation because the patient can lose the vision.
I have a question. What are some good triage questions to ask? Like if, say, a patient calls in with those kind of symptoms.
Sorry. Yes. What is the question?
So if patient calls in, we're trying to like triage, symptoms. What are good like red flag questions?
So a good question for someone. First of all, you'll see the patient. You'll see that the lesions respect the midline. You'll see usually that it respects one dermatome. And the good question is to ask them if they ever had herpes, if they ever had cold sores. Okay? Because if they have herpes, it means that it's in their body and then it can flare. When patients have fever, when they are stressed, it can flare up. Ask them if they had any episodes in the past. Okay? Of course. Next questions. So 37-year-old present with photophobia, blurred vision after working on his car brakes. His vision is 20/60 in the right eye, 20/40 in the left eye. What is the most likely diagnosis? Is this answer good or too small? And all those cases actually were in the urgent eye clinic. They are real cases.
I know. I also have to get
Good job. So let's talk about cornea. What do you see here? What is it? Very big foreign body. And it's on the cornea. And foreign body flags. So if patient complain about photophobia, light sensitivity, blurry vision after mechanical work, suspect foreign body until proven otherwise. Many people work during the day, go to sleep, and then during the night, they are waking up with excruciating pain because it's very, very painful. The cornea has a lot of nerves over it, and then it wakes them up. And it's critical to find it. Why? Because it can treat the vision loss. It can cause ulcer, and it can perforate the eye. It can cause severe eye loss. Okay, ready for the next one. 24-year-old, 3 weeks of right eye irritation after hammering metal without safety goggles. He initially thought it was a scratch and treated with antibiotic ointment. What is the most concerning diagnosis?
I think
That's good, actually. Corneal aberration, it is concerning, but intraocular foreign body is much more concerning. Corneal aberration with antibiotic, 24, 48 hours, probably will resolve. Intraocular foreign body, they will need surgery. And it cause devastating consequences. And Patrick,
Settle down.
Patrick, where do you work?
I work at the Plum at Pittsford.
I can't pick Patrick.
Okay. So, yes, this is the retina. There is foreign body there, metal inside the eye. And actually, this patient, it's very weird story. And the patient came and he saw an eye doctor, and the doctor told him, I don't see anything, everything looks great. And then he waited 3 weeks and he still felt discomfort. And then he came again, and another doctor noticed that there is an injury in the eyelid. It was very suspected injury. And actually the foreign body go through the eyelid and just penetrate the eyelid and the eye. Ooh. And he could lose his vision, he could lose the eye, but he had luck because someone saw it. Okay. So intraocular foreign body, red flags, unilateral discomfort after high velocity metal work, treat as penetrating injury until proven otherwise, and escalate urgently. Because again, it can cause infection, retinal injury, permanent vision loss, and loss of the eye. Next question. 39-year-old contact lens wearer with worsening eye pain, redness, photophobia, decreased vision after swimming in a lake. What is the most likely diagnosis? Yes, so it could be. Yeah.
Well, you better be prepared as a medical student.
Corneal ulcer, good job, guys. Very, very good. Patrick, very, very good. Also, Amanda, Maria, good job. Suzanne. So here you can see corneal ulcer. It's a very big one. There is some infiltrates and the patient probably can't see. You'll check the vision will be very, very poor, maybe count finger, maybe even a hand motion. The eye will be very irritated, very red, and he will be in pain usually. So, red flags, eye pain, redness, photophobia, blurry and decreased vision with contact lens were used. Always ask when someone say that you wear contact lens, ask them if they sleep with the contacts, if they swim with them, if they shower with them, because if they do, it can cause a lot of complication. It's very bad. And also tell the doctor what the patient usually does, because the doctor should be aware and discuss it with the patient. A 53-year-old patient, history of keratitis, present with vision loss in right eye. History concerning, he used topical anesthetic. He got it from the ED. So what do you think that is the not likely diagnosis now? Yes.
Yes, Susan, I didn't, I just. Yes. Yeah.
I love that for you.
I didn't change. I just.
Wow. Okay, Amanda, you are very close to Patrick. Also Maria, actually. If you answer faster, you'll get more scores. I want you to win. Don't get me wrong. Okay. So topical anesthetic abuse, patients that because of the pain, they have abrasion, and sometimes the ED unfortunately give them propiocaine, topical anesthetic, and it can cause this very bad ulcer, and it will not heal. The anesthetic prevented the epithelium from healing, and can cause also vision loss and loss of the eye. And look, you can see that it's chronic, because you can see all the vessels over the cornea. So it's very chronic. This patient used the anesthetic for a long time, unfortunately. Red flags, persistent epithelial defect, worsening pain after topical anesthetic use. You'll give him the anesthetic and you still have pain. Usually they don't have pain after anesthetic, but the nerves are gone. So you will still be in pain, but it's more deeper. No. And anesthetic abuse can cause severe corneal toxicity, corneal melt, perforation, and permanent vision loss. That's the reason that it's very important to ask the question, what medication do you use? Okay? Yeah. Okay. Patient with history of multiple corneal transplant for Fuchs dystrophy and glaucoma tube shunt present with a sudden vision loss in the left eye approximately 2 days ago. What is the most concerning diagnosis? Okay, I'm not going to close the questions faster, but I want to ask you all the questions. I don't have enough time. So each time, around 10 seconds, I'm going to close the next question. Good job. Corneal perforation. Wow. Good job, guys. Okay, so here, actually, there was transplant here. It's not there anymore. Just out. There is nothing there. All open block. Very, very serious, unfortunately.
How do you fix something like that?
cornea get involved and cornea transplant. Yeah, but it's urgent. Iris cornea transplant, with sudden vision loss, you have to escalate immediately. Maybe they have a wound leak, maybe infection, corneal melt, graft failure, and perforation. So there are other things that can cause damage and irreversible vision loss in patients after corneal transplant, but it's very serious, those patients. If they have red eye, it's very suspicious. 39-year-old with ankylosing spondylitis present with 2 weeks of painful red eye, photophobia, blurred vision. What is the most likely diagnosis?
The only thing I know.
Internet sauce.
Okay. Going to the next slide.
I'm moving out.
So this is uveitis, and what do you see here? Can someone describe what is it?
Sneaky, I've never seen it.
Thank you.
So the pupil, instead of being circle and round and nice, there is synechiae. And also there are some cells you can see it here. But in the slit lab, we'll see cells, we'll see flare, we'll see that there is a lot of activity in the anterior segment of the eye. Yeah. Red flecks of anterior uveitis, painful red eye, photophobia, blurred vision, especially in patients with ankylosing spondylitis. So those patients usually have rheumatoid diseases. Ask them, do you have joint pain? Do you have any treatment for rheumatologic disease? And escalate promptly. Concerns. If they have also, you can ask them about HLA-B27. If there is any diagnosis of HLA-B27, they have more suspicious to have anterior uveitis. And if this condition is not treated, it can cause irreversible vision loss. Next question. 81-year-old with sudden severe eye pain, red eye, blurred vision, headache, nausea, aloes. What is the most concerning diagnosis?
Yes.
Okay. Job, acute angle closure glaucoma. Okay, so what do you see? Oh, what do you see here? The eye will be very red. Usually the cornea is more cloudy, it's not clear. The pupil will be more dilated. Okay, and the patient usually will have excruciating pain, will be in a lot of pain. Usually older patients that never did glaucoma surgery. And painful red eye with decreased vision, aloes, headache, nausea, a mild dilated, poorly reactive pupil, very concerning. And why it's concerning? Because eye pressure will cause damage to the optic nerve. And if the optic nerve has a lot of pressure over it, it will just die. It will cause atrophy, and the patient can lose the vision in 5 minutes if the pressure is very high. It's very, very urgent. It's emergency. So if you see the pressure very high, go directly to the doctor. Don't continue with refraction and asking question. If the pressure is like 40 and above, go to the doctor directly, okay? Yeah. 43-year-old developed right eye pain, AZ vision, having a drink, blacking out overnight. He doesn't know what happened. What is the most likely diagnosis? Okay. Good job. Patrick, you did it very fast. Good job. Okay, so here you can see this is how traumatic iritis looks like. There is ifema, there is blood clots that just accumulate in the inferior part of the anterior chamber. And it is concerning because it can stain the cornea, and it can cause also elevated eye pressure, and you can lose the vision. So if you notice something like this, tell the doctor. The doctor probably will see it with the slit lamp, but if you also notice it, tell the doctor. Red flags, traumatic eye injury, AZ decreased vision, visible blood in the anterior chamber, and it's urgent because usually they can also rebleed. Again, staining of the cornea, optic nerve damage if the pressure is elevated, and permanent vision loss. 48-year-old woman with myopia, prior LASIK, posterior vitreous detachment. Now she's telling that she has new floaters, shadow, but the vision is 20/20. What is the most concerning diagnosis? Good job, yes. So it's retinal detachment.
Yes.
Even though the vision is 20/20. Amanda. Wow. Good job. Okay, so here you can see this area. This is retinal detachment actually, but it does not involve the macula. That's the reason the vision is 20/20. If the fluid will come and will elevate the rest of the retina, it will also involve the macula, and the patient probably, the vision will be much poorer. So this is urgent because if the retina specialist will not treat it same day, it will get worse for sure. Macula on retinal detachment, and here is a autofluorescence, and you can see this bubble. Again, the macula looks preserved, but there is a bubble there. And the red flags are if someone has new floaters, shadow, flashes, you have to escalate immediately because macula on retinal detachment is urgent. We can save his vision. Next question. 61-year-old with sudden vision loss in the left eye, described as veil coming down. Now his vision is, in the left eye is 2400. So he has poor vision in the left eye.
Like hairs. Yeah. I feel it now.
Yes. I agree that it's a tricky question. Sudden vision loss can also be central retinal artery occlusion. Usually if veil calm down, floaters and flashes, most likely retinal detachment. But here it was a tricky question. I agree with you guys. So, and double run. Okay, so here is the retinal detachment that is involving also the macula. And that's the reason that the vision is very poor. And this is also urgency, because if they will not fix it, the patient will lose his vision. But if they will fix it with retina surgery, he will gain his vision back. It will not be as good as the macula on retinal detachment. It's going to be still poorer vision, but it will be better with surgery. If we will not have surgery, he can lose the eye. The pressure will get elevated, he will develop some neovascularization, and cause devastating results. So this is autofluorescence, and you can see this bubble, and also here you can see that it involves the macula. Macula of retinal detachment. Usually the patient will complain about curtain over his vision, markedly reduced vision, and we have to escalate immediately. It's very urgent. Okay, now we have to run all the questions faster, or we will skip some questions. So let's start with this one. 44-year-old presents with blurred vision, eye pain, mild dilated pupil, report the recent episode of shingles. Cold sores. What is the most concerning diagnosis? This is actually a little bit hard case. Okay, I'm going to the answers. Wow. Jesse? And this is Arn, acute retinal necrosis. There is infection, herpes in the retina. There is necrosis all over. The vessels are constricted. This is urgent. If we will not treat it, it should be evaluated by retina. It should get antiviral treatment, intravitreal. And if they will not treat it, you will lose the vision. Acute retinal necrosis. So someone with blurred vision, eye pain, recent shingles, cold sores. Immediately think about ARN also, because it's rapidly progressive. If we will not stop it, it will cause much more damage. Next question. 84-year-old woman with wet AMD present with 3 weeks after intravitreal injection, Avastin injection. Now she has pain, discharge, blurred vision, visual acuity in the left eye, and motion. I'm going to stop it. Good job, Jesse. And this is endophthalmitis. It's infection of the entire eye. And you can see here, there is hypopyon, there is discharge. It's very injected. The cornea is very hazy. It's very, very serious. The patient can lose his eye.
Does the vision come back?
If they treat it, sometimes it improves. Usually usually they don't get their normal vision again, unfortunately, but they can improve it. Red flags, so eye pain, discharge, significant vision loss after injection or any intraocular intervention. Escalate immediately, it might be endophthalmitis. 67-year-old patient with a history of hypertension, diabetes, present with sudden painless blurry vision in one eye. The patient denies eye pain, redness, flashes, hurting. What is the most likely diagnosis? Amanda. Okay. So this is central retinal vein occlusion, and you can see that there are a lot of bleeding intraretinal hemorrhages all around the retina. And this is serious. CRVO, sudden painless. There will not be any pain. It just suddenly will not be able to see. It's usually patient with vascular risk factors. So always ask your patient, do you have any other general diseases, hypertension, diabetes, hypercholesterolemia? Okay, it's very important to ask those questions. And CRVO can cause severe macular edema, retinal ischemia, neovascular glaucoma, and permanent vision loss. Another patient went to the grocery store earlier this on 5 p.m. Noticed sudden painless vision loss in the right eye. His vision has not improved since then. What is the most concerning diagnosis? Also painless. And I'm going to the answers. Whoa.
Yeah, but I don't know if I got it.
And the ether, 17 rounds, you're correct. Okay. So this is central retinal artery occlusion, and it's hard to see, but here there is a red spot. There is edema in the macula, and there is just red spot in the center. And this is like a stroke. It's very, very serious. This patient can have stroke. So CRAO, central retinal artery occlusion, sudden severe painless loss, especially with vascular risk factors. So again, ask about hypertension, hyperlipidemia, diabetes. And this patient, actually, we sent to the ED. It's emergent. They can have stroke, they can die. So CRAO, very, very, very concerning. 76-year-old, prior melanoma, somewhere in the skin, gradual left vision decline, discom, transit visual obscuration. What is the most concerning diagnosis? Good job. Okay, so this is melanoma. Patients with history of melanoma can develop melanoma, choroidal melanoma, and they can die. This is devastating. This is very, very, very bad. So always ask about the general health condition. Cancers. Cancer is very important, and it can also involve the eyes. And this is how in ultrasound, that's what we would see in this scan. It's huge. Choroidal melanoma, history of melanoma, and new progressive unilateral visual symptoms escalate immediately because it might not be dry eye. It might be something much more serious. Okay. 19-year-old overweight patient, severe headache, worse in the morning, nausea, vomiting, pulsatile tinnitus. What is the most concerning diagnosis? I give you 10 seconds and then I'm going because we will not finish the presentation.
It's really wonderful, doctor.
Marie. Where is Marie? Marai. Good job. Where do you work?
Sorry, I'm a different brain. My name is E. I am number 10. Right. Oh, right here, right. Hi.
You're doing good job. Okay. So papilledema, you can see here are the optic nerves. Usually the optic nerves are very sharp. There are sharp margins. Though you can take a pencil and just draw it. Here, I can draw it. It's like very blurry. And also it's more red. And when I look in the slit lamp, it will be elevated. It's not flat. Usually the optic nerve is flat. This will be elevated, blurry. Many times there will be hemorrhages around. And also the edema will be so severe, so it will obscure the vessels around. It will be vascular obscuration. Papilledema, morning headache, nausea, vomiting, pulsatile tinnitus, transient vision obscuration. They will tell you that suddenly they stop saying everything is black and then it comes back to normal. This is very concerning, especially overweight young females. Escalate immediately. They might have intracorneal hypertension, and it might be even tumor in the brain. So it's very, very serious. Okay. 83-year-old woman present with temporal headache, jaw claudication, scalp tenderness, decreased vision. In the right eye, vision 20/20 in the left 20/25. What is the most concerning diagnosis? Good. Yeah. Giant cell arthritis. Oh. Okay, so giant cell arthritis, it's older patient. They will say that they will have tenderness here when they are eating. They have pain here, weight loss without intention, fever, and some blurry vision, visual disturbance. It's very concerning. They can lose the vision. They can also lose the vision in the other eye. They need immediate evaluation. Most of the time, they will go to neuro-ophthalmology. Vasculopathic 59-year-old with hypertension, pre-diabetic, obstructive sleep apnea, using CPAP, chronic kidney disease, migraines, 2 weeks of painless vision loss, no jaw claudication, no temporal artery, temporal pain, no fever, no weight loss. What can it be? I'm sorry that I'm running it. I want to finish the presentation. Okay, so it's non-arthritic anterior ischemic optic neuropathy. And you can see that this optic nerve looks different from this one. This one is sharp margin, this one blurry margin. And this is urgent. And this is a OCT RNFL, and you can see that the RNFL here, there is a lot of edema. It's 151 micron, and here it's 86, so there is a lot of edema. And also, this is also a thing that you can ask. Those patients usually will describe that part of the visual field, the inferior part, is missing. So you can ask them, do you have any visual field deficits? Nyon, painless vision loss in vasculopathic patient, especially if he has hypertension, diabetic, obstructive sleep apnea. And we should escalate. It can cause permanent vision loss, and they should be evaluated by neuro-ophthalmology. 45-year-old returned from Mexico, suddenly noticed drooping of the eyelid. She described that she had some neck massage, and we looked at the pupils, and there is difference in the pupil size. What is the most concerning diagnosis?
There's mom's not worried about.
You know,
That's
I
it.
forgot the name.
So this is Horner syndrome. Ptosis, meiosis, and anitrasis. It means that it's very, very serious. She might have, it might be something that involves the brain. It might be lung tumor, and it can be carotid dissection, and carotid dissection, all of them can kill actually. But carotid dissection can kill immediately, just die. They have to go to the ED emergently to do some imaging of the neck to see if there is any carotid dissection. And after neck massage, it's very suspicious. Also, it's very interesting, but sometimes they go to salon, and when they do their hair, yeah.
Really? Huh.
Yeah, be careful. Okay, Horner syndrome, unilateral ptosis, smaller pupil on this side after any neck manipulation. Escalate immediately. Ninety-year-old patient with dementia, atrial fibrillation, on a liquis. He has also hypertension, hyperlipidemia, diabetic mellitus, kidney disease, and e-transfer after unwitnessed fall. Found he has some swelling eyelid and fractures. What is the most concerning diagnosis? Good job. So compartment syndrome. It can bleed into this orbit, and it can cause irreversible damage. It will cause optic neuropathy, and it can lose the vision. So it's urgent, and usually we intervene and we do ear cut, and we just release all the pressure. Very, very urgent. Trauma with anticoagulation, orbital fracture, tense eyelid, escalate immediately. 62-year-old with hypertension, diabetes, sudden diplopia, right ptosis, the right eye is down and out. And she has limited eye movements and larger pupil. What is the most concerning diagnosis? This is hard, it's neuro. It's hard. But you should know about it, because they can die. This and dilated pupil, think about third nerve palsy. If the eye is down and out, limited eye movement, dilated pupil, it's very concerning. 58-year-old, new binocular double vision, vertical. The diplopia is worse when looking down when she's reading a book. She reports improvement when tilting the head to the opposite side. What is the most concerning diagnosis? What is most likely? You know what? It's not 6. 4. If it improves when tilting the head, usually 4. 6, they will not have vertical diplopia. 6, they will have horizontal diplopia, okay? Corner, new vertical diplopia, usually worse when they are reading, when they are walking on stairs. And it's serious, of course. Okay, 4 more questions, 5 more questions. A 67-year-old with hypertension, diabetes, horizontal diplopia. Worse when looking to the right side. There is limited eye movement. You can't move the eye to the right side. What is the most concerning diagnosis? Good job. Okay, so this is 6 nerve palsy. This patient trying to look to this side, but he can't. There is palsy of the 6th nerve. It's serious. 6 nerve palsy, new horizontal diplopia, limited abduction, worse when looking through the affected side. Prompt escalate promptly. 90-year-old experienced transient vision loss in the left eye lasting 30 seconds to 3 minutes with complete resolution. Like nothing occurred at all. Is it serious? Now we feel great. Very, 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 very serious. It's TIA, transient ischemic attack, and he might have stroke. He also can die in the next couple of days. So if someone see black and he's older, let the doctor know. We will also discuss with him, but let us know, because we sent this guy to the ED. Very, very serious. Okay. 64-year-old patient, progressive bulging of the left eye for several years. Suddenly double vision, restricted eye movements, the vision in the left eye 2200. What is the most concerning diagnosis? The longest straight. Good job. Yeah, proptosis, limited eye movement, restriction. Usually they complain about dry eye, thyroid eye disease, and it's urgent. Because if they had they can have that thyroid neuropathy. Because of the muscles, they can push over the optic nerve and it can cause irreversible vision loss. It's urgent. 54-year-old left side facial drop, including inability to close the eye, weakness of the forehead, denies arm, leg, weakness, numbness. She denies any other symptoms. What could it be? She said that yes, she feels discomfort in the eye. So this is Bell's palsy. And there is weakness in one side. She will not be able to close the eye. The eye will be very dry. Most of the times it resolves on its own. Sometimes it's associated with herpes and they need antiviral treatment. But we should evaluate it urgently because it might be stroke also. So it's serious. Last question, it's very, I consider it to show it to you, but it's hard one, but I want you to be aware. 2-year-old boy with no significant ocular, any history, level 1 trauma, finding include multiple bruises, some marks on his skin, some burns on his skin. He has retinal hemorrhages. He has a toxic injury. What is it? Winners.
You're buying lunch.
Where are you? Power catching red flags. Good job, guys. So this is abusive and trauma, and it's serious. And I just want to summarize everything. Your role is critical in identifying red flags. Someone with acute vision loss, severe eye pain, double vision, restricted eye movement, just be aware, ask all the questions that you can think about and escalate immediately. Motivational video. I had to finish with something like dramatic.
Hey, I keep saying, I think
What?
Thank you, Dr. Arnon. That was excellent.